Ramalu and his team for giving this opportunity to me. Thank you, sir.
Thank you very much, sir. Thank you. Thanks a lot, sir. Now, the latest peel is a pumpkin peel. Pumpkin peel, very costly. What is being told is 10 gram of pumpkin peel needs in and around 10 pumpkins. 10 pumpkins grinded to 10 gram of pumpkin peel. Right? The advantage of pumpkin peel is it's not irritating, it's not burning. That is the basic thing about pumpkin peel. Your glycolic peel, TCA peel, your mandelic acid, your pyruvic acid, your lactic acid, your glycolic acid, everything has little amount of irritation and will lead on to post-inflammatory complication also. Here is one peel where we don't end up with any post-inflammatory complication. As such, it's not a peel. It's something like a facial pack only. I tell it's a beauty parlor product. But unfortunately, people are after this pack only. So we have to know about this pack. This pack is dark brown in color. Apply it onto your face. It dries out within 8 to 10 minutes. After drying, leave out for 1.5 hours. Leave out for 1.5 hours. But what people do is apply, immediately wash. If it is sensitive, wash. If it is not sensitive, you can leave it for 1.5 hours like a facial pack. Otherwise, it is sensitive within 5 to 10 minutes, wash it. If you can leave it like a pack, the results are good. If you don't leave it like a pack, the results are not so good. For that matter, I told you it's not exactly a peel. It is going to be something like a facial pack. Now, we are going to discuss about the PRP. PRP, platelets. In blood, RBC is 93%. Platelet is 7%. You reverse this. The platelets to be 93%, RBC to be 7%. This is PRP, platelet-rich plasma. Platelets-rich plasma. 93% of platelets. How to do it? Take blood, put it into a centrifuge. Leave it for 10 minutes, 3000 RPM. The uppermost portion with the buffy coat. Uppermost portion and the buffy coat is going to be platelets because platelets, the density is low. The density is high with RBC. Everything is in the downstairs. So leave that down coat. Here it's a pale coat. The pale coat, along with that buffy coat, remove it. It will be in and around maybe 3 ml. You take 10 ml of blood, you will get 3 ml of platelet solution. Take it and then add calcium chloride. Before starting, we have to add acid citrate dextrose because anticoagulant to be added, otherwise the blood will coagulate. Add that and then go in for centrifuge, take the uppermost coat, then again re-centrifuge, take the lowermost coat, take it. It will contain maybe around 1.5 ml to 2 ml of PRP. First coat, upper coat. Second coat, lower coat. This is the thing. Because platelets have low density, lower than your RBC. Take the PRP, it can be used in. After finishing off, add a 1 drop, 0.5 ml of calcium chloride. 0.5 ml of calcium chloride will activate your platelet. So now it has become an atom bomb. A platelet activated with calcium chloride becomes an atom bomb. It can be used in hair rejuvenation, it can be used in scar revision, it can be used in stasis ulcers, it can be used in vasculitis. FDA has approved PRP in leg ulcer and vasculitis. All others not approved. But now we are conducting trial. We are doing 30% success with PRP. not 100%. You should not think that PRP is 100% curative, 100% effective. It's not like that. 30% curative in hair disorders, 30% helpful in acne scars, 80 to 90% helpful in vasculitis and leg ulcer. 10 cases of leg ulcer, pour your PRP inside, cover it, you will get a tremendous response. Any ulcer for that matter, any ulcer on your leg. You have a big trophic ulcer which is not healing. You have a big tropical ulcer which is not healing. You have a stasis ulcer which is not healing. You have a vasculitis which is not healing. Take the PRP, take it from his own blood, apply it on the ulcer, leave it for 10 days, close it, leave it for 10 days. What I do, my experience. For a trophic ulcer, I take the PRP, add a little amount of mupirocin ointment, make metronidazole powder, make it into a paste. PRP, mupirocin, flagell. Cover the whole trophic ulcer. Above it, apply region D or a collagen sheet. Above it, a sofratul, cover it, leave it for 10 days. 9 out of 10 patients will have a remarkable improvement. You will have a very good granulation tissue. All leg ulcers, all vasculitis not responding to therapy, PRP, mupirocin, flagell powder, above it, topical region D, otherwise human epidermal growth factor, above it, sofratul, cover the whole lesion, leave it for 10 days, open it, you will have tremendous results. PRP in the head now. See the PRP fluid. I have prepared already, right? This is how we have to inject. This is a male pattern baldness. We can't inject more than 2 ml. 0.5 ml in one spot, 4 spots we have to take. One, we start from the occipital area, 0.5 ml. Same way, another 0.5 ml. Another way, 0.5 ml. What happens to these patients? The fibrotic nature of this androgenetic alopecia is brought down. I told you, in androgenetic alopecia, scarring alopecia, the basic problem is the fibrosis. If you can break the fibrosis, the medical treatment whichever you are going to try may be successful, or surgical treatment which you are going to try may be successful. So before going in for a full-blown hair transplantation, now in our department what we do at least 6 sittings of PRP, then go in for hair transplantation. 6 sittings of PRP in a gap of weekly twice, in a gap of 3-4 days, 6 sittings. After 6 sittings, go in for a surgery. That will have good results. So, any hair restoration surgery, do PRP, then go in for restoration surgery. In hair restoration surgery, I told you, follicular unit transplant. You will be very happy if you finish one surgery, because it's so easy like that. It's so easy like that. Very, very easy. I told you, follicular unit transplant, it's very easy. The machine is very cheaper. Otherwise, just on a microdermabrader, attach that probe onto a dermabrader, 0.9 or 1 mm, start it immediately. You do one case, you will become an expert in the second case. PRP in acne scars. I told you, again here too we have to take 4 spots. See, after subcision only I am doing this. Without subcision, you are not to do any procedure for any scar. Any acne scar, first thing to be done is only subcision followed with any procedure. You can do PRP, you can do microderm, you can do dermabrasion, you can do laser, you can do chemical peeling, anything. But subcision preceding any surgery. Iduva? Right, yeah. Now we go for Botox. Botox is a boon. This is 50 units Botox vial. 50 units Botox vial. We have to add 1.25 ml. 100 units vial, we have to add 3 ml. 1.25 ml for 50 units, 2.5 ml for 100 units. To make it 0.1 ml is equal to 4 units. See, 50 units vial, 50 units vial, 1.25 ml of saline. 100 units vial, 2.5 ml of saline. This will make 0.1 ml is equal to 4 units. 0.1 ml will be 4 units. How to go about with Botox? This is a face. You have a wrinkle here. Not more than 40 units in one face. Not more than 40 units in one face. Not more than 20 units in one breast. Not more than 40 units in one head for migraine. 20 units for breast augmentation, not more than 20 units. Not more than 40 units in one head for migraine. Not more than 40 units in one face for wrinkles. Not more than 40 units in one hand for palmoplantar hyperhidrosis. So, for what all things we use? 1, wrinkles as an anti-aging procedure. 2, it can be used in palmoplantar hyperhidrosis. 3, it can be used in migraine. 4, it can be used in 4, it can be used in breast augmentation. 5, now we have started using in Raynaud's. These 4 things are given in book. Now we have been doing this Botox in Raynaud's for the past 1 year now. We have got tremendous results. I will show you few cases of Raynaud's. How do we give Botox? How is the result like? I will tell you. See, here there are 3 wrinkles. 4 units in one area. Give a gap of 1 inch, 4 units, 4 units, 4 units, 4 units, 4 units, 4 units. Below the eye, anywhere below the eye, 2 units. See, above the eye margin, 4 units. Below the eye margin, 2 units. Gap of 1 inch. But what I normally advise is, don't ever do Botox in the facial nerve area. This is the facial nerve area. Be very careful. If at all you need, you can give 2 units. But be very careful. You will definitely end up with tissue injury. You will end up with droop. You will end up with facial palsy. Be careful. Right. We end up with a droop. We end up with a facial palsy. What are you going to do? We have to have clonidine. Clonidine comes in eye drops. Clonidine comes in injection. Clonidine, aproclonidine. This clonidine, you get a droop of the eyes, immediately put 3 to 4 drops of clonidine inside, it will come up. You can inject it into areas where we develop facial palsy. Definitely we will develop, if at all you are going to go here. We don't know we know very well that it's going to be richly innervated by peripheral nerves. Definitely there will be a mild damage. What I do, I catch hold of the skin, make a thin flimsy injection, see the needle and inject. So be careful if at all you are injecting below the eye. Above the eye, you can be free to use. One thing, the gap between the eye, gap between any orifice and Botox should be more than 1.5 centimeter. See, this is my eyebrow. If I am going to inject Botox here, I have to give a gap of 1 inch here, 1 centimeter. If I am going to inject here away from the nasolabial fold, I have to give a gap of 1 centimeter again. 1 centimeter here, 1 centimeter, around any orifice, 1 centimeter. Same way, if I am going to inject it into my palms, see, this is the palm. What I do is, lateral margin to be left out. Lateral margin to be left out. Right? 4 units here, 4 units here, 4, 4, 4, 4, 4. The lateral margin to be spared. You can inject 2 units here. But don't go laterally. This is palmoplantar hyperhidrosis. Breast augmentation, Botox, you are going to paralyze the pectoralis minor. Pectoralis minor helps the first 15 degree of abduction. So you give Botox for breast augmentation, you are definitely going to lose that 15 degree abduction. It will be slower. See, this is faster abduction. You give Botox, it will be slow. Then it comes up fast. Pectoralis minor, first 15 degrees of abduction, after that pectoralis major. Pectoralis major forms the major chunk of the breast muscle. You paralyze pectoralis minor is the contracting muscle. See, this is pectoralis major. Your pectoralis minor is here. You paralyze that pectoralis minor, the contracting muscle action is gone, 30% increase in breast size. So this is the basic thing in Botox. How to go about lateral side of sternum, 4th intercostal space, 20 units into this chest, 20 units into the chest. First hit will be on the intercostal muscle, second hit will be on the pectoralis major, pectoralis minor, withdraw, inject the 20 units. Immediately it will go in for a paralysis within 15 days. The breast size will increase by 30%. It can't be increased more than 30%. We can't make a big pumpkin out of a small lime. It is just 30% increase. What I advise is, combine Botox with breast augmentation mission. The results are so good. I will tell you how to go about that breast augmentation mission later on, because now lots and lots of people, the failure in life is all due to decreased breast size. How to increase that breast size? Botox plus breast augmentation. See here the wrinkles. See how I am putting my finger there so that I don't go near the eye. See that angle, 45 degree angle. 45 degree angle. See that 45 degree angle, 4 units, that's it, 4 units, 4 units, 4 units, 4 units, 4 units. Say you have crow's feet. You have crow's feet. Here we have to inject only 2 units. How to go about? Say this is crow's feet. See this. Draw a line there. Fan it out. And draw a line here. How to go about? 1 centimeter beyond that. So 2 units here. 2 units here. 2 units here. Don't go near the eye. Don't go near any orifice for that matter. Then migraine, Raynaud's. Now I am going to inject for Raynaud's. This lady, I have done 4 sittings of Botox earlier for this lady in a gap of 28 days. in a gap of 28 days. I have been doing this for Raynaud's. Remarkable recovery. Everybody who has a case of scleroderma with Raynaud's, connective tissue disorder with Raynaud's, please try Botox. How to go about? So this is the interdigital web space. 2 units there. 2 units. 2 units. 2 units. 2 units. 2 units. Right. 2 units. 2 units. 2 units. And we have published a paper also on it. Botox in Raynaud's. Remarkable effect. I told you few cosmetic procedures, remarkable effect, of which this is one remarkable effect. In all Raynaud's, please try Botox in the interdigital web space. In the interdigital web space, 2 units. 2 units. Give a gap of 1 month. Again, you can redo if at all there is a need. There will be a definite improvement. In migraine, this is the head. If this is a frontal area, occipital area, 10 units, 10, 10, 10, 10, 10. See me, I have migraine. 10 units here on the center, 2 inches above your forehead. This is the forehead line, 2 inches away from that. Same way, draw a line there. Draw a line here. 4 inch from that earlier point, 10 units. 10 units here, 10 units here, 10 units here. 40 units, the migraine will come down. Again, the success rate is going to be 60 to 70%. Nothing is permanent, nothing is permanent, nothing is permanent. Migraine, 60 to 70%. Wrinkle, 80 to 90%, everything will go off. Palmoplantar hyperhidrosis, 80 to 90%. In case of complication, use clonidine. This is palmoplantar hyperhidrosis. I told you how to draw a line there. See, don't go laterally, don't go laterally. I'll just show you one hand now. See this. See this. In all other areas, we are paralyzing a muscle. Here, we are not going to go deep. We are not to go deep. Otherwise, you will end up with flaccid paralysis. Here, you have to see the needle. See, I think you are able to see the needle there. You have to see the needle. It has to be very, very superficial. We are just going to block the acetylcholine. Acetylcholine gaining entry into the acetylcholine receptor through the STAR complex is being prevented by Botox. So we are not paralyzing a muscle here. We are just containing that acetylcholine. So we are not to go deeper. We are not to go deeper. Not more than 40 units. Not more than 40 units in one hand. Not more than 40 units in one hand. 2 units you can do. Filler. Now we are starting with filler. Filler, this is hyaluronic acid, commonly used, normally no complications, short-lived, may last for 1 year, 2 years, it will come down. Again, we have to go in for a repeat filler. But this is the best filler. In a hyaluronic acid filler, this is the best filler. With this hyaluronic acid, there is, when we use a filler or when we use a scar, there is one hyaluronic acid moisturizer also. I'll show you the moisturizer. This is hyaluronic acid serum, hyaluronic acid ointment, hyaluronic acid serum, hyaluronic acid ointment, This will be a best moisturizer for the skin. In any anti-aging treatment, what I normally tell is, use a good sunscreener in the morning, good moisturizer in the night, your age will not go up. There is a good saying by Mark Twain. Mark Twain has told, when you are born on earth, your age should be 80. Your age should decrease, it should go up to 18. Start with 80 when you are born, and your age should increase to 18, 18. This is Mark Twain. This Mark Twain's ideology can be fulfilled by this. Morning sunscreener, a good sunscreener. Evening, good moisturizer. Hyaluronic acid serum moisturizer, hyaluronic acid cream moisturizer. This is something like a small solution, you can just apply it. Really, this is going to do wonders. Daily, if at all you are going to use this, at least you can break the age barrier by at least 10 years. You can't bring back nature for 8 years to 40 years, but you can delay the aging process. Everybody, every dermatologist, we have to be handsome, we have to be beautiful, we have to sit in a practice. If you are not beautiful, no patient is going to come for cosmetic procedure to you. So, we have to use all these things. What is natural? Hyaluronic acid is natural, either serum or ointment. Sunscreener is a must for all cosmetologists. Moisturizers at night, all cosmetologists should do it. Fillers, I told you this is temporary filler. Nothing is permanent on earth. Permanent filler says that it may be 3 to 5 years. This is temporary. Here, this has a crisscross scar. Earlier we did fat transplant for this scar. Now I am doing fillers for this. Just a trial between your fat filler and this filler, natural filler and artificial filler. See how I am doing it. Start from the edge. I think you are able to see the needle. Inject it, bring it down. 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 Where needle கொடுங்க? இது கொடுங்க. இந்த needle வேண்டாம். பெரிய needle கொடுங்க. A bigger scar needs a bigger needle. A small needle for a small scar. Otherwise, what happens is, it will leave out beaded appearance. எடுக்க முடியாது. லாக் ஆயிடும். அதெல்லாம் எடுக்க முடியாது. சிசர் எடுப்பீங்களா? ஏமா ஆட்ரிமா, ஆட்ரிக்கு தேடுவாங்க பாரு, எல்லாத்தையும் எடுத்து வைக்கிறத விட்டுட்டு. Bigger scar, we have to go in for a longer needle. Now you will be able to appreciate, because you leave out beading, it won't go out. See, I think you are able to see the scar now. You are able to see the scar. Scar is above my needle. Now what you have to do is, inject it, slowly withdraw, and withdraw. That's it. See the scar now, it has been filled up now. Underdo, don't overdo. We can fill it again, no problem. But the extrusion rate, the failure rate of any filler is in and around 60%. Fat. We showed that autologous fat transplantation. See, this amount of fluid we have got now. This is a natural filler. I showed you how to take that fat. Now we are just going to fill it out. See, this is a small scar, a small needle. A small scar, small needle. You are able to see that? You are able to see that scar? This is a fat filler. You can mold it also, but after maybe around 1 or 2 weeks, if it gets a good amount of blood supply, the regeneration will be very nice. Next. Intralesional. Cryo. The oldest thing, oldest dermatosurgery instrument. Now we don't use. What I tell is, this is hardly used nowadays. Minus 196 degree when it is inside the chamber. Minus 80 degree. Minus 80 degree when it is in this flask. The most sensitive temperature, the most sensitive structure in the skin will be melanocyte, minus 20 degree. The least sensitive structure in the skin will be fibroblast. Melanocyte, fibroblast. Melanocyte minus 20, fibroblast minus 80. So you should attain a temperature of minus 80 for keloids. For cancerous skin lesion, whether it is basal cell carcinoma or squamous cell carcinoma, hard dose of cryo will be equal to your laser. Hard dose of cryo will be equal to your laser. See, what I do is inject intralesional steroid. Along with that, a cryo, it's going to act like an immunomodulator. The basic problem in alopecia areata, your immunology, the T cells is going to fight against the hair root. So throw your T cells away from that hair root, you are going to get a cure. Right? Same way, this is keloid. Now, for all keloid, we use intralesional steroid along with Hylase. Intralesional steroid along with Hylase. Earlier we used to tell only intralesional steroid. Now for ganglion, keloid, smaller neurofibroma, we can use Hylase with intralesional steroid. See, now I have mixed Hylase with intralesional steroid. Intralesional steroid complications are minimized when you mix Hylase with it in keloids. Same way in ganglion also. See, this is Hylase with intralesional steroids mixed together, apply. Along with that, you can go in for a cryotherapy. Gap between one dose of Hylase intralesional steroid in keloid to the other treatment will be 15 days. Before doing a cryo in keloid, create a small wall with some bland ointment, because you are not to burn the surrounding tissue. I told you the most sensitive structure in the skin is melanocyte. When I tell it to be melanocyte, it's going to produce post-inflammatory hypopigmentation. Any bland ointment in a cryo for BCE, squamous cell carcinoma, in alopecia areata, in keloid, in a corn, in a wart, use a small coat of bland ointment serum surrounding the lesion and do a cryo. Given intralesional hyalase with hyalase with steroid. That will be of good use. Right. Very good. Ganglion. Next one is ganglion. Previously we used to tell அந்த மாதிரி பேஷண்ட் வெளியே எழுதிடணும். Ganglion. Hyalase was earlier used. Now what I am doing is I mix hyalase with intralesional steroid. I told you in keloid we were using intralesional steroid, mix hyalase along with it. In ganglion we were using hyalase, mix hyalase with intralesional steroids. The results will be good. Smaller neurofibroma in the face, multiple neurofibroma in the face, smaller lesion, we can go in for hyalase with intralesional steroid. The results will be very nice. See this is a ganglion. Go vertical, go vertical, go vertical, right? You are into the material, inject it, after 15 days we can see for that. If at all there is a need, we have to go in for a second sitting. If not, we can just stop with one sitting itself. But there will be a recurrence of ganglion. We know that there will be a recurrence in ganglion, doesn't matter. If at all it recurs, we can very well go in for second therapy. Neurofibroma hyalase. See, this is a neurofibroma. Neurofibroma. Again, hyalase injected inside it. I think you are able to see that. See this? See this? Again a neurofibroma, a smaller one in the face. Inject it inside. The results will be very nice. Right. 15 minutes. Now this is a case of dermoid cyst. Anybody, if at all they are hungry, anybody who want to taste the buds, the food will come to the chair. You need not come all the way. It will be supplied. This is a case of dermoid cyst. People used to think how to go about in a dermoid cyst also. Again, hyalase with intralesional steroid in dermoid cyst. It will go down flat within 15 days. If it does not go down, inject another time. At least within two sittings it will go down. See this? Again, it should be perpendicular. See that injection. There will be a swelling. Everything will get melted out like a strawberry ice cream. Water. In a wart, which is not responding to your cautery, not responding to cryotherapy, not responding to any acid treatment, not responding to any acidic treatment, we can use interferon. Interferon is available in 3 lakh units. Interferon B, interferon alpha and interferon beta. You can use anything. 3 million units. 3 million units injected into a wart. Recurrent wart. Plantar wart, not healing with any therapy. Inject this interferon like your intralesional steroid into it. It will have only 1 ml of fluid. I didn't get a case. If I get, I will demonstrate it to you. Just inject it inside, the wart will all fall off. But since it's a passive immunity, there may be a recurrence. Then what is the use of these things, sir? When you want to have a cosmetic improvement, this all happens. We should explain the patient that we will try to help them. We will try to help them. We will not promise too much. We will not expect too much. In case of complication, we will help you out. Sclerotherapy. My subject, my interesting subject. We started this in this department before 9 years. We started this for hemangioma, a classical case of tongue hemangioma. A tongue hemangioma, you can't go in for a laser, you can't go in for anything. Tongue hemangioma, if you go in for a sclerosant, it will get diluted. But we got a remarkable result. I will show you. You go to IJDVL, foam sclerotherapy in vascular malformation by Dr. G.R.RATNAVEL. I have explained it in a clear way. Foam sclerotherapy in vascular malformation by G.R.RATNAVEL. Here, there are few things. This is sodium tetradecyl sulfate. Polydecanol can be used. Hypertonic saline can be used. The basic phenomenon here is your endothelium should come into contact with the sclerosant and it will become a fibrotic cord. How are you going to do it? You put the needle inside first. Blood comes out. Evacuate the whole lesion. Inject the sclerosant. Put a pressure bandage. See, there is no blood inside the blood vessel now. Only the sclerosant inside the blood vessel. This is the blood vessel. Say this is a varicose vein. You inject it inside. Blood comes out. Evacuate the whole amount of blood. Press it. And then inject your thing. Now it's all only sclerosant. When it is sclerosant, slowly it will become a fibrotic cord. Later on it will become a fibrotic cord only. This amount big vein will become a fibrotic cord. Same way in a hemangioma. Sometimes we don't even get blood. We may inject it outside the blood vessel. It may go in for necrosis. We had a case of necrosis also. In that case also, the result will be so good. But how to go about? In a hemangioma, not more than 2 ml in one hemangiomatous skin lesion. In a lymphangioma, not more than 2 ml in one lesion. Say if you are going to do a sclerotherapy in lymphangioma circumscriptum, not more than 2 ml there, not more than 2 ml in hemangioma, but in a varicose vein, in one patient, one sitting, we can go up to 10 ml. 10 ml of sclerosant. The sclerosant has to be diluted 1:1. If you are afraid, we have to dilute it to 1:2. Not more than 10 ml in one vein. Not more than 2 ml in one spot. The gap between one spot and the other spot is 2 ml. 2 ml. 2 ml. 1 inch gap. So 10 ml in one vein. Not more than 10 ml in one vein. Evacuate the blood content. Inject it. Pressure bandage. These are the 3 main things in sclerotherapy. Put the needle, blood comes out, evacuate, inject, and put a pressure bandage. Not more than 2 ml in one hemangioma, not more than 2 ml in one lymphangioma, not more than 10 ml in one vein in one individual. Right? See this foam. See, this is air. 1 ml of sclerosant, 1 ml of sclerosant, 5 ml of air. See how we are preparing that. Sclerosant is in one chamber, the other chamber is all full of air. See the foam which is coming out. The foam is to see that the sclerosant is in that place only. It does not get diluted and it does not disappear into other areas. Foam is to be in that one area only. That is the main thing. Now the foam has been prepared. See the foam. You see that fluid, sclerotherapy. See, this is a plain fluid. See this is a plain fluid. See the foam. We are injecting the foam only. This is foam sclerotherapy. See how I am injecting it. See this hemangioma. You may think that there will be a hectic amount of bleed. Don't worry about that. Even if you don't get the bleed, inject it into the surrounding areas. It has all become a fibrotic cord. I am straight away injecting it inside. See, straight away injecting inside. It will be painful. The indicator of stopping the procedure will be pain, 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 pain. If there is hectic pain, we have to stop it. But we have to be slow, 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 slow. See the foam there. See the foam there. See the foam there. Pressure bandage, pressure bandage, pressure bandage. This is the thing of sclerotherapy. If at all you end up with complication, don't worry. The complication will be necrosis. Complication will be necrosis. The results will be so good. Even if you get a complication of necrotic ulcer, the result will be nice. So don't worry. Mucus cyst cool bone top. Cool bone top. See this mucus cyst. I think you are able to see that. See that mucus cyst. Burn it with the cautery or radio frequency. The only thing is that you have to remove that mucus material. If you don't remove, again it's going to recur. And any amount of injury produced on the lip will heal off naturally. Don't worry. You need not go in for a suture. You need not go in for a cut. You need not go in for an elliptical incision. You open it with this and you need not even close. See this? I think you are able to see that mucus cyst. I've gone inside, opened it. Now we have to extravasate the contents. Extravasate the contents and then burn it. See that material coming out? I think you are able to see that on my nail. See that mucus material. After you remove that, again burn it. Again burn it. You can even char the tissue, doesn't matter. There won't be any recurrence. I think you are able to see that. The mucus material to be removed, that is the basic thing. If you don't remove the mucus material, again there will be a recurrence. Again we can do, no problem. Underdoing is better than overdoing. Okay. Now, a callosity. Callosity is an adaptive phenomenon of the skin to frictional areas. Thank you, sir. 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 Thank you. adaptive skin phenomenon, adaptive skin response to frictional areas. Wherever there is friction, the skin goes in for callosity. The skin goes in for conformation. So, as such, it's good. It is adapting. It is preventing the further damage of the skin. But when it becomes painful, we have to remove. Otherwise, it's not going to do any harm. See how I am removing it. I think you are able to see it. Burn, burn, burn. It will come of its own. You need not take it. Don't ever try to take it. It will be something like a popcorn. It will come of its own. Till then, burn it. Don't cut it. Don't cut it. Don't cut it. Burn, burn, burn. See how it falls off? See this? Simpler. You need not go in for a bigger surgery. The only thing, don't cut it. You may leave out remnants. Don't do that. Surrounding the lesion, just do a radiocautery. Everything is out. Finished. See that? I think you are able to see that. Nothing is present inside. See this? This was inside. Like that. Everything has come out. Right? So it's simple like that. collagen நீவை இதில் இதில் போட்டோம் அதே வச்சு எடுத்துறேன். So instead of going in for a blade removal, surgical removal, wasting the time of the patient, this is very, very easy. Simpler surgeries. Now we have a case of collagen nevai. These are all few interesting cases. How to remove a collagen nevai, because it's actually no need to remove a nevai, but sometimes if at all it produces problems, then we can go in for removal. குடிக்கலைன்னா வீட்டுக்கு போயிடணும், கிளம்பிடுங்க. See, this is a collagen nevai. I think you are able to see that. See that? Able to see that? Even a neurofibroma, you can cut it this way. Simpler, no bleed, nothing. Hardly takes 2 to 3 minutes. Simple surgeries, make it simpler. No need of antibiotics, nothing. Just a topical closure will be enough. It's going to recur, doesn't matter. The patient is happy, symptomatic benefit. The patient was very discomfortable with all these things, and he had problems. The patient had landed up with problems in familial things also, so she wanted to remove. Right? It's so simple like that. After that, you can just burn it out. If at all we think that there may be a little amount of bleed, we can burn it. That's it. So see the lesion. It's so simple. Right? Then நீ பண்ணிருமா. Radio frequency cautery does not need sterilization. We can sterilize it by increasing the joule strength to above 80. Hold it for 1 minute, the needle is sterilized. Your electrocautery needle, other needles all need sterilization. Radio frequency needle does not need any sensitive sterilization. So, you want to use a cautery thing, use a radio frequency cautery. That will be better. This is milia. This is milia burnt out by radio frequency. Radio frequency or electrocautery on the face not to exceed 6 joules. In the body, it can go up to 6 to 20. In a tumor, it can go up to 80. In a cone, we can go up to 90. So in the face, not more than 6 joules. Not more than 6 joules. So this is milia. Angiokeratoma. Routine sebaceous cyst, normally what we do, we put an elliptical incision, remove the skin, remove the contents, remove the sac, suture it. Now I am just going to demonstrate it, how to do with the radio frequency cautery. I am a lover of radio frequency. What I think is, radio frequency is better than laser in lots and lots of conditions. If you do a comparative trial between laser and radio frequency, in multiple conditions, radio frequency is superior. Radio frequency is cheaper, radio frequency is superior. In tumors you can use, in skin rejuvenation you can use, in hypertrophic lesion you can use, in wart we can use, in milia we can use, in angiokeratoma we can use, in hemangioma we can use, in radio frequency tightening is also being used. In hair removal, along with IPL, radio frequency is used. So radio frequency, normally thought that laser is number one. It's not that way. Sebaceous. Right. See this sebaceous cyst? See it? There's a big punctum. Just go inside. Now squeeze it. See that material coming out? This is to minimize the trauma which is being produced by surgery. See the amount of sebum which has come out. After removing, either we can use trichloroacetic acid for burning the sac, or we can use the cautery itself. I will show you how to burn out. Now the material has all come out now. See, material has all come out. Again put the needle into the same area where we went inside. Burn it. Burn this sac. Burn this sac. I think you are able to see that. Burn this sac. This can be done in sebaceous cyst of the scrotum, sebaceous cyst of any area, because the only damage will be in and around a small hole. This small hole will all definitely close out within 15 days. Otherwise, what we can do is, instead of doing a radio frequency, this is trichloroacetic acid. You can inject the trichloroacetic acid inside the lesion, inject it inside, leave a gap of 1 minute, squeeze it, neutralize it. See the brown color there, that's TCA changing there. Squeeze it and remove that TCA. So we can do both. We can do either with radio frequency, or we can burn it, or we can cauterize it. Both ways we can burn the capsule to see that it does not become recurrent. But even after removing, it can become recurrent. That is the way the dermatology goes. 70% of skin diseases are not curable. So one patient sees you today, the next day he will see you, your friend, the next day he will see another friend. In a period of 30 years, you will see all dermatologists in the city. Bread and butter for all dermatologists. A beautiful branch, wonderful branch, no cure for anything. Everything control, control, control. You can't even cure an insect bite for that matter. But we will say we will cure, we will try, we will try. I have a big board in my clinic saying that what are all the skin diseases which are curable. I have written around 80 diseases. 3 diseases are curable. Fungus, which is an infection. Bacterial infection, impetigo, is curable. Right? All others, 6 months to 60 years. Acne vulgaris start from 6 months. Connectivity disorder till goes to 60 years. No cure, no cure, no cure, no cure. By seeing that, patients also come. So that's the way the practice is going now. See, angiokeratoma scrotum. I told you angiokeratoma scrotum or sebaceous scrotum, simpler with radio frequency. Don't worry about the bleeding. It will bleed. Make it higher. Make it to around 60 so that it does not bleed. See that? See that? Angiokeratoma scrotum. See that? I think you are able to see. Angiokeratoma is a surgical emergency. We have to cure the patient immediately. See how lots and lots of angiokeratoma. One angiokeratoma patient who had bleeding went to a urologist. That urologist had asked the patient to go in for, the patient has told that the bleeding is per urethra. So he has done all investigations which can be done through the urethra. Ended with the infection of the urethra. Later landed up in Apollo hospitals. The doctor who was treating was an infectious specialist. He called me just to see the patient. I told them it's all just angiokeratoma. Everything has been done in a wrong way. 2 minutes, everything will be over. Burn it with a radio frequency, things gone. So, angiokeratoma normally bleeding per urethra. This will be the history, but it's not urethra. If it bleeds at night, life is endangered. So we have to be careful. GP, the only thing is maximum amount of joules in a radio frequency apparatus. 1, 2, char the tissue. Char the tissue, char the tissue, char the tissue. Don't ever try to remove the radio frequency needle from the lesion till it gets charred out. You remove it and again you go in for radio frequency. The bleeding can't be stopped and it will bleed, 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 and you won't be able to finish the procedure. See, this is GP. See that? Till it chars, don't leave. Till it chars, don't leave. Till it chars, don't leave. Otherwise, it will bleed profusely. I think you are able to see that charring. It's not the finger, it's the GP, so don't worry. That's it. Perfumes, deodorants, seborrheic keratosis, radiofrequency, burn the lesion, leave it off. If it has a peduncle, you can cut. If it does not have a peduncle, don't cut. Just burn it. It will fall off within a week or 10 days. Six joules over the face, 6 joules, not more than 6 joules. In a non-pedunculated lesion, please don't touch the lesion. Fulguration will be the best technique. Fulguration, fulguration, fulguration. See, just fulguration, that's it. This will all fall off within 15 days. Few demonstrations now. I told you neurofibroma, we can go in for injection Hyalase with steroids. Now I will show you how to remove it also with radiofrequency. Instead of surgical removal, we can go in for see how is it coming out. See how I am burning. Minor things. You should have lots of cases of neurofibroma. This is very easy. Give injection. If not, you can remove with this cautery itself. Simpler. See that now? I have opened it. See that? See that? Now we can catch hold of it and then we can remove it. See, it's so simple. So it's simplest surgery like that. One neurofibroma over. You can remove 10, 15 neurofibroma in one sitting. See that it does not bleed. A dermal structure, definitely it's going to bleed. See the neurofibroma? Simpler like that. Instead of going for an incision with radiofrequency. Xanthelasma palpebrum. just a superficial burns. It may require 2 to 3 sittings. It may require 2 to 3 sittings. Within one sitting, we may not expect a good result because it may recur, doesn't matter. Again, if it recurs, we can go in for a second sitting. It will go off. Perfumes and deodorants. No deodorant except for dire need. Otherwise, no perfume, no deodorant onto the skin. Perfume, at least you are going to spray it on the shirt, but some people spray the perfume onto the handkerchief and repeatedly smell it. They spray the perfume onto the handkerchief and they smell it. What happens? The fumes from there, because it's all just fumes, it contains benzyl alcohol, it contains benzaldehyde, it's something like cigarette smoke. Again, it's going to produce syringoma burning. Syringoma, there will be recurrence. Don't worry. Even if there is recurrence, we can go in for a second sitting or third sitting. The only thing, we should not produce a scar there. Just few dermabrader. Simon Fraser இருக்கா? Simon Fraser. மூணு இருக்குன்னாங்க. டைமண்ட் ஃப்ரேசர் அப்படின்னா என்னன்னு தெரியாது அவனுக்கு. நேற்றே சொன்னேன் ஃப்ரேசர் வாங்கி வைங்கன்னு. கிரான்லோமா, tattoo granuloma. I told you we can go in for either intralesional steroids or we can go in for a dermabrasion. Granuloma, we can't go in for a laser because here we are not reducing the pigments. Here we have to remove that skin and we have to wash it. How to wash it? Wash it with normal saline, no problem. So why you go in for a tattoo, then why we end up with complication, why we have to remove. There was a girl who had a tattoo in the thigh. The name was Johnson. I was doing a removal for that girl. I asked her, who is this Johnson? Johnson is my boyfriend. When is your marriage? After 1 month. Now who is your husband? Edward. You're going to get married to Edward. You've forgotten this guy. No. This is for me. Edward is for my father and mother. So lots of girls, foolish girls doing foolish activities and then getting it removed is increasing in number. Movies predict this way. Movies tell that your love can be shown through tattooing. So naughty, foolish females also do the same thing. See, I have done a dermabrasion. Now I have opened the skin. We can wash it with saline. After washing, inject intralesional steroids. After washing, inject intralesional steroids. With intralesional steroids, even with intralesional steroids, 20 to 30% reduction will be there. Without going in for intralesional steroids, it won't get completed. So even though you you do a dermabrasion, You wash it, give an intralesional steroid injection. Thank you, sir. 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 Thank you. Thank you. So now injection is being given. So in a tattoo granuloma, there are 3 steps: dermabrasion, washing, and then intralesional steroids. But the basic problem is, I had one case of tattoo granuloma in the lip. The lip was like a Hanuman, pathetic situation. But I told you, even a big knife cut on the lip will give a good healing. So, opened that lesion with the radio frequency, gave a wash, removed the pigment, left along, around 2 months, everything healed out. You need not go in for a suture itself. The results will be very nice, very nice, very nice. So, you need not worry about it. Right. This is a case of gynecomastia. I told you, in a gynecomastia, not more than 20 units of phosphatidylcholine onto one breast. One lipoma, not more than 10 ml. See how we inject it. This is phosphatidylcholine. Again, we have to go in for 4 quadrants. Round is it? See, there are 4 quadrants here. Each should focus the nipple only. Each should focus the nipple only. This is a gynecomastia. So, from 4 edges we have to inject 5 ml. From 4 edges we have to inject 5 ml. But don't go near the nipple. It has to be in the angle of the nipple, but don't go near the nipple. See how I am going along the nipple line, 5 ml, 5 ml, 5 ml, 5 ml. So, not more than 20 ml. This is not just phosphatidylcholine. This has phosphatidylcholine with deoxycholate. No phosphatidylcholine alone for obesity or gynecomastia or lipoma, nothing. Everything with deoxycholate. It's called PPL. PPL. See, this is a port wine stain. Port wine stain, what we do is, this is esmolol drops, otherwise beta blocker drops. This is used as an injection. What we do is, we just apply this injection. See, just apply it over that. Beta blockers over these lesions. With beta blocker of 50 milligram dosage or 25 milligram dosage, 50 milligram dosage or 25 milligram dosage as a systemic therapy. So you get a case of port wine stain, you give 50 milligram of atenolol or 25 milligram of atenolol depending upon the weight with beta blocker solution topical. Beta blocker solution topical comes in the form of metoprolol, which is available as injection, esmolol, which is available as injection. You can apply anything, but the result will be around 60 to 65% improvement in that. At least that coloring will definitely come down. So port wine stain, a combination of atenolol 50 milligram with esmolol. Right. An interesting case again. This is Nasovion drops. Nasovion drops is used for nasal decongestion. In cosmetology, where we use acne rosaceae. In all acne rosaceae, wherever erythema and tingling sensation is very, very severe, use this Nasovion drops. Ask the patient to apply topically, not into the nose, topically onto the skin. 70% improvement. 70% improvement. So, with this plain thing, we can help lots and lots of patients of acne rosaceae. Lots of patients complain of burning skin. Lots of patients complain of erythematous skin. Ask the patient to apply this one and give a systemic minocycline or Flagyl, everything will come down. Break. Now we will go in for a lunch break. Lunch break, 15 minutes. We are already late. Be fast, be fast, be fast. Be fast like me.